Welcome to the next episode of the LIT Show. The LIT Show is a program organized by Dr. Raut's Center for Reproductive Immunology. This center is located in Mumbai, where we treat couples with repeated pregnancy loss, unexplained IVF failures, and unexplained infertility with the help of reproductive immunology, especially with the use of lymphocyte immunization therapy and other immunomodulatory treatments. The purpose of the LIT show is to welcome or to have an informal chat with eminent gynecologists, IVF specialists who believe in reproductive immunology and whose patients have been benefited with reproductive immunology, and also patients who have been benefited with the use of lymphocyte immunization therapy and other immunomodulatory treatments. Today we have a very special guest from Ahmedabad, Dr. Jayesh Amin. Welcome, Dr. Jayesh.
Thank you so much for inviting me on this LIT show. I'm just waiting for this type of the show where you can invite me and I can give some reviews. So thank you so much for inviting me, Dr. Mugdha and Dr. Raut.
So, Dr. Jayesh Amin has done his MBBS and MD in obstetrics and gynecology. After that, he has done his fellowship for IVF and embryology by Lars Johnson, Sweden. He is currently the clinical director of Wings IVF Hospitals, group of hospitals at Ahmedabad, Rajkot, Surat and Udaipur. He is the current secretary of the Indian Fertility Society, Gujarat chapter, and he is a convener of Fertility Preservation Society of IFS. Also, his Ahmedabad Wings Hospital has an affiliation with Amity University for 1 year training in clinical endocrinology and clinical embryology.
So welcome, Dr. Jayesh Amin. It is indeed our pleasure to have you here on the LIT show. And as we know that you are an expert, not only just an expert in the field of IVF, but you are considered as a thorough academician, a researcher, and much more in this field, and your methodical approach to the problem. All these things we would like to know from you in this episode. So to begin with, sir, the first question that comes to our mind is, how did you develop interest in the field of fertility or infertility? Can you throw some light on it?
See, you know that sometimes we in MBBS and after MD, when we are getting admissions in gynecology. So, you know, before way back in 1999 or 2000, everybody is in gynec is a very small field. And it's the initiation of the vaginal hysterectomy era and then followed by laparoscopy era. I'm just discussing within half an hour before my one doctor who is referred me patients, and she arrived here and she says that, doctor, same question what she asked. I said something the first time in my annual exam of PG when I'm doing gynec, there is a 2 option of essay writing. We have a 2 essay writing, right? So there will be a 2 essay writing which says something like that, minimal invasive surgery versus AR. And you won't believe that I attend ART where I'm just knowing the very superficial knowledge at that time, because you know that at that time ART is just very superficial way back in 2002, 2003, right? So very few people are doing. So what I'm saying that after that, I can consider that if you are any branch, if you say onco or something orthopedic, but in our gynec, 2 things are more important: giving birth your hope, right? And I'm feeling that if you are giving birth of any woman, and the motherhood is always blessed for anybody else, anybody in the world, whether it is riches or poor or whatever. And then I find out sometimes I'm just walking with anybody, I find out how people are happy at the end of the day. and how they are sharing the happiness. So I decided to go by the fertility expert that this is the right time, because it's not only that you are earning, it is all about the job satisfaction. And I
Right.
feel something about in the world that you are the richest person as far as concerned the satisfaction. So my funda is behind that, not be riches by money, but no, it should be riches by your happiness. And this type of happiness always come when you make some people happy. That is the world biggest happiness in your life, that you are making so many couple happy in an ethical way, in a good way, whatever the things will be there. Right. So that's why I choose fertility science, and it's my passion to go towards to giving the happiness to the couples. This is my intentions toward this choosing fertility science.
So that's nice, Dr. Jayesh. So can you just tell us since when you are in this IVF practice, and how did you begin?
So I started my IVF practice in 2004, I think so, where I started my first IVF baby, which was not, it is simulated at my center, and then it was shifted to the, uh, we have a IKD hospital in Ahmedabad, where they have a lab. So they invited me that if you have a freelancing, you can do stimulations. And at that time, I'm taking all the training sessions. So I say, okay, I can go by. And that is my patient, one first patient that I stimulated and went there. So initially, what I started with the IUI lab in my private center, and I'm stimulating the and using the IVF lab of the others. So that I had done something about a minimum 100 patients for initial 100 patients for up to 2006, 2007. And then I initiated my own lab with a joint venture with my one good obstetrician friend. And way back then we have started with the IVF lab. So I can say something in Ahmedabad, in western part, especially in Gujarat, the first IVF was started in 1999 around. The first IVF center was started, and after 2001, 2002, there are another few more centers started. So if you consider that, as far as concerned the number of the centers, we are one of the first 5 centers, those who started IVF in our Ahmedabad or in the Gujarat part. That one of me, I myself also will be included in this one of the first 5 who started the IVF. And then that's it. Then journey goes on regarding. So my main intention, previously I'm focusing on some obstetrics. You know that previously people are focusing on both, but my partner helped me a lot, that say, doctor, you are the person, you focus on more on IVF. And then I left everything and I focused on IVF only, because I love laparoscopy also, because my career was started with laparoscopy, where I left laparoscopy in 2009. So 2000, after 2009, I left laparoscopy also, that another expert surgeon. I had done everything. You can tell me something about TLH or grade 3, grade 4 endometriosis, everything which was done at my clinic by me. And I'm performing at 2010, we are end up with the around 50 cycles a month. That is what we are doing at 2010.
So how did wings start? That was that the wings, or the when did the
So
wings come
previously,
into existence?
when we started, it is a joint venture where we started as a I started in a Pujan hospital, which is something you can say at that era where people are having a just to start the IVF, but they don't have a something vision regarding the further, that what will be the name or like that. So we started with the very basic name of Pujan IVF Center. Then within a 1-2 years, looking to you guys, Bombay people are always having a hate for us, and they are always thinking more that how to put you in market. So I feel something. This name is not looking catchy. Let us put this name that which should be some internationally accepted, that people will, that if you in the future, if you use this name, then people will accept, in even the people, those NRI will come. So I started to find out the name, and then we changed the name. It is something Boon IVF Center, BOON. And you can understand what is Boon. That means in Gujarati I can say it's Ashirwad, right? So I say this God Ashirwad, that we want to deliver by giving you a baby. So I choose something Boon IVF Center, BOON. Then we take this journey up to 2013, that we named it around Boon IVF Center. And in 2013, I depart from my partner and started my own only IVF center, which will be a standalone building in the very richest area of the Ahmedabad. And we started where only super specialty, that we can do only laparoscopy by the other super specialist surgeon, fetal medicine by the super specialist surgeon, and myself will be only focused on IVF. And that will be wings mean women's infertility and gynec endoscopy division. So its full family, full name is like that. So that's why we make it wings. And when I make this name, that we decided we have to fly with our wings to everywhere in the India. That is our aim. That is what we want to do in the further also.
Great, great. I think we know that you have very, very scientific and systematic approach in your practice in your IVF, and you have a very logical way of deriving the diagnosis, and therefore you have got very good success rate for your patients. So can you tell more about it, so that people can know more about your ways of looking at the problem of IVF or IVF failures?
Because since we know you, Dr. Jayesh, we have always seen that your approach is very systematic.
Yes. Thank you so much for your kind words. But let me tell you something, the history of IVF, and we all people are aware of how the history of IVF started in 1974, where 13 pickup was performed on the Louis Brown, right? So it may be a different trial. It's a different experience by Robert Edward, right? But in up to 90s, I think so, up to 2000, IVF science is very prima science, where there is something, you can say 3 or 4 instrument is a only box incubator, ek dabba hai, okay? And you can have a one laminar airflow, which is also Indian one, and you have a 2 incubators, or 2 microscopes, these all things. And the embryologists are very scarcity. There is a lot of freelancing of embryologists also. So making an embryo is a challenge up to, I think so, 2005. So everybody is making an embryo, means lab who is making an embryo, that is fine. It's a good lab. And we all are just up to day 3 embryo, no advanced culturing of the embryo, everything is going on. But people are just in the awareness is less. So if you ask me, the leading those who started, even the number of the cycles, number of the people are coming very less. So I know that in 2003, the person who started first time in Gujarat, they are also struggling to get 30, 40 patients a month, right? So this is, I think so, 2008, and you know that in polycystic ovary, people are afraid to go for IVF, means because of the complications. Because if you start IVF, you can always have every 7 days, if you have a good number, every 7 days you have one PCO patient in your ward, which the hyperstimulations and OHSS, everything. So we pass through that also, that we are having always OHSS, and I'm a little bit worried in the night and my sleepless night, not because of labor pain and delivery, but my sleepless night is because of the OHSS. That because I'm worried about that something, if it occur wrong, this very young lady who she treated, but if something is occur very wrong, then it's very difficult to explain the patients. But I think so there is lot of changes which occurred, and I went in Germany in 2009, and this is the biggest change of the world. I think so first launch of antagonist is 2007-8. 2005 is invented in the Europe, and it is coming in India is around 2007-8, and we started antagonist to use. And I am surprising to say something, that's a miracle injections which will make this OHSS free, right? At least we don't have a routine OHSS because of the antagonist in the younger population. So this is again a one change. In 2008, the bench incubator which is arrived, which also make a very senseful, that we can make the prolonged culturing, and then followed by, I think so, time lapse and everything. So my vision is that putting yourself in always to increase 1 or 2% result. I'm always investing every yearly something, some rupees, some my fund to increase the technology, because this technology will help it out, because without technology you cannot help it out. The 25% of the part of the IVF is technology always there. So that is the first way. Second, now I know that if what nature is doing, nature is doing day 5. So I know that your goal should be day 5. I read a lot of literature. I went through the lot of clinics of the Europe and a lot of clinic who started earlier blastocysts. So my methodological approach, again, I want to say that we are pioneer in Ahmedabad. I know 2013 NISAR and 2014 NISAR, when there are a lot of seniors are gathered on the dais and asking that day 3 and day 4. And as routinely people are saying that there is no data. So I don't believe in data. I believe that what is your experience, right? So if your experience gathered, which is really saying you that it is all ethical experience. So we moved 2011 to blastocyst, 2014 to freeze all, and we started 2014 first PGD thalassemia free baby. So these are the advanced techniques. So now I can understand that you have to become more smart to give higher pregnancy rate, become freeze-all, day 5, and then even though pregnancy is not then what will be there? It is only two things is important, that whether his embryo is not good or whether his endometrium is having a window period, the other science, right? So that what we are doing very methodically, and now we are getting that, okay, now this is something. See, I still not believe that if somebody says that your live birth rate is, I'm not interested in live birth, I'm interested in for embryo transfer for IVF cycle live birth, right? So that is important. It's not important something you are combining obese patients and hypertension patient and thin endometrium patients and a lot of immunological disorders patients, every patient, and you say something era live birth rate is 70%, but segregate the population, then you can say PGT era is having a higher success. It's a way forward to touch higher success rate. See, nothing is 100% in the market in the biological science, but we need to go by step, that first you need to change the environment to make the day 5 blastocyst, then you can have a freeze all, then you can have a transfer the whenever the PGT is required, especially in the advanced maternal age, recurrent IVF failure, because embryo is 80% responsible for the implantation failure. So if you first see the embryo is good, then nothing to worry about. And now what if I'm looking to this 30 years, 25, 30 years generation, those who are coming for IVF for some indication, they are not in a trial concept. They are saying, doctor, and on the first day of IVF, people mindset is one is done. हमारा गुजराती में कहिए कि एक साइकिल में થઈ જશે સાહેબ. I can understand. I can understand their internal psychology they want to do. Now, I'm not explaining that it is available, but I'm saying that I'm trying by polymorphism to prevent the hypo-response, because then we can get more eggs than more embryo. I'm trying that making all the people to go for blastocyst, then selection is good. I'm trying beyond blastocyst, then we can have a PGT as and when required. And I'm trying to go for the freeze also. There will be no something random implantations. And there are a lot of disadvantage of the freeze site, right? And lastly, I can say PGT era. But still, now I'm coming to your point. I know that where I required LIT and where we meet because of the all these things which all failed, then what to do.
Yeah, exactly. Actually, what we wanted to know was, in spite of this systematic approach, you must be still facing at some stage that there are challenges in managing this or difficult to manage patients. So what do you do for such patients, and what do you think is the possible factor in that?
See, my first counseling to the patient that PG at present, what about the recurrent implantation failure? You need to just first finish the PGT era. That will be the first approach, in which blastocyst, freeze-all, PGT era. Now I'm counseling that what is there about the output. So people are asking that now, sir, everything is completed. I have a 2 embryo in your cryo lab, and my endometrium is, my uterine lining is good, my uterus is good, I'm not obese, my husband factor and my age background, everything is fine. Now what is your story? I say that these are the very, very much positive factor where you will get result, but at the end of the day you will not get 7 out of 10 or 8 out of 10, or sometimes the best will be 6.5 out of 10 also, right? Even after expecting everything. So I already counseled in the first that beyond this era, everything which is immunology and bacteriology, these are the two science which is, I think so, the research and lot of things are already researched, but still it is evaluated in this immunology and bacteriology. So I always explain and keeping them open this window that if everything is failed, then okay, you have an option of immunotherapy or might be bacteriology science to find out your lactobacillus score inside your uterine lining, and let us see about we can do also. So my Dr. Roth, if you ask me the previous month in post-COVID, we have done 100 pickups also. But let me tell you something, out of this 100 pickup, we have around 91, 92 a self cycle. So let me tell you something, my ratio of self cycle is very higher. If you ask me, the average advanced maternal age is 20 to 30% of my patient is having an age more than 37 years, 30% patient. Today I have got 3 cycle strategies, all age are 41 and 42 years. So you can, and I explain them, you have to have a 3 or 4 pickups, you have to have a eupride 1 embryo, that is the thumb rule. So don't go and cooperate me for multiple pickups and cooperate me for genetic testing and cooperate me for freeze-all and then ERA, and then we can transfer a single embryo, right? So this is my explanation to them. You need to expand means money will be there, right? And see, my counseling is also very perfect to the patient that if you see the budget, see everybody is budget their life, and if you see, look out your budget of your life, what your expenditure at the end of the 80 years of your life. If you see the budget of IVF or LIT or whatever the therapy, it's not never than more than 10 lakh rupees, right? But if you see you're buying a car from Maruti to Mercedes, if you are buying a house from 1 BHK to 4 BHK, you are buying a clothes from normal to branded clothes. So everybody is interested to also traveling to international tours, everything. And if you find out your life budget, then whole life budget is my budget will be last. And where this budget you are doing something, you are creating a big bungalow and villa, and you are traveling in anything, anyway, you are enjoying or something. But if you are childless, then what? Then what? If you want to live in family, nothing is that you will enjoy every time you are in depressions, right? So I'm saying that this budget is nothing. And this is my explanation. Even those who are lower middle class, I'm saying that I can reduce. But then you have to cooperate me. It's not like that I am only going to reduce the money and you are not cooperating me to accept the advanced technology. Maybe it's PGT, ERA, LIT and everything. So the purpose of telling this is that LIT is a therapy which is an extra cost to the patient. And if they say something like that, I'm not going to, because I'm 80,000 or whatever the cost will be there. I don't know exactly. We all people are knowing what is the cost. But then say, oh, this is the extra budget, doctor, I will not bear it. I say, what are you doing, man? Right? So this is my explanations, and my methodological approach is there. Once I failed by everything, I will be always in support of Dr. Raut and Raut couple that, okay, Dr. Raut, please help me out. I am sending these patients for immunotherapy and let us see that if she is getting, because these are the most frustrated area that they had done all the extra things which is available across the world. I already said I'm doing the practice like if Aishwarya Rai is coming with Abhishek Bachchan, and if she is something, I'm giving doctor you 10 crore rupees, the same treatment I am offering to my Geeta or Sita, which is not Aishwarya, right?
Right.
You are all our Aishwarya and we are offering you Bacha only, and we are interested and so passionate that you become a mother by your own gametes. That is what our main intentions. And let me tell you, my intention for future might be let I make my clinic is a donor gamete free clinic, right?
Great.
Where I can give, right? But I am not saying that donor should not be advised. There are a lot of couple, so I'm not against. The message should be not like that to the community that donor should be stopped. It is not like that. The 20% of the populations which might require donor, it might be POF, it might be absent ovaries, it might be some genetic disease, it might be menopausal woman, right? So this premature menopause. So these are things. So it's not evitable. So it's inevitable. So don't say something. Yes, that donor is not required in the society. Donor is the requirement of the society in certain population. But improper use and improper methodological approach will turn out to use of 60% of donor instead of 20%.
Oh,
That's most important part, that if you go by methodological approach, then you cannot waste your embryo. That embryo is a 9-month live pregnancy, but it is wasted because of the random all protocols, which is not meticulously approached.
that's great. I think that's a very good approach, Dr. Jayesh, yeah, because if it is donor-free clinic as far as much as possible, it's a great idea. So I think it's an excellent approach to have such a clinic where there is minimum use of donors. But what and you were telling about the immunology role of immunology also. So can you highlight a little bit more? What is your experience for some of your difficult to treat patients related to use of reproductive immunology and maybe lymphocyte immunization therapy at our centers? Because we have collaboration for quite some time, and quite a few of your patients were with us, and they were really difficult patients, and they have failed many times at different other places, and you have managed them successful. So can you tell your experience about this?
So first of all, I would like to congratulate both of you that this is a very difficult area that you choose, and we are happy to announce, happy to say something about that. Previously, when there is recurrent pregnancy loss, suppose a patient who is coming for 7 abortions, 8 abortions, what I'm doing? Straightforward, I'm advising that you need to change a body. If patient wants their own gametes, I said it's not changing of gametes, it is always you change your body. That means what? The body response is going to change. At that time, we are not aware, or there is something, a primary level of LIT therapy is there, right? So we people are not aware, and we are doing, I'm saying it's way back when you are arrived in the, for LIT therapy. You started a very way back long, but I think so your presence in everywhere will be something slowly in the every part of the India, right? And at present, you are the only option for us that we are sending the patients, or all people will send the patients for LIT therapy. So previously we are doing surrogacy, and we are getting a female who she aborted 8 times, and she will deliver a 3.2 kg bacha with a surrogate mother. And from that day, I clicked that the body which is responsible, something should be changed from the body. That means the immune response. And if you want to change, then you require you have to change the response, immune response from her body. And I can share now my patient something that, and I changed something that first patient I want to share, very recent patient. A doctor, husband, wife, both are doctor, right? And who both are 3 times PGT and ERA, failed in other clinic in my Ahmedabad, right?
Right.
And they arrived here to say something, because we 2 people here in Ahmedabad, so we 2 people are always having exchange of the patients with the patient. When there is a doctor or certain category patient, they say something, okay, Dr. Jayesh, we were allowed to take opinion from your side. Our one embryo is there, and it is PGT tested. And what can I do, sir? And that doctor patient is also having PGT tested embryo there and 2-time abortion. So I said, okay, you can transfer this embryo. But meanwhile, this is a lockdown period. I said something, after that transfer you go, I will talk to Dr. Raut. He said, I have a number. Okay, then she is a doctor, right? So he said, I will go. Okay, ma'am. I say, okay, you go. This is the number, and you share my name. So these both are super specialty doctor. They came to your center. This is very recently, I said before 4 days back, that PGT embryo transfer is failed in that clinic, right? And they said, okay, now I will go to Dr. Jayesh Amin, because already immunotherapy in between given by you, right? And they called me, okay, immunotherapy taken. I said, you are young, and this much of failure, you can come after 2-3 months. That's okay. Don't come before 2-3 months. And within these 3 months, they got a natural pregnancy.
Oh.
So this is what I want to say something. Those who are having a recurrent pregnancy loss, naturally or artificially, if they are very young, the message is very straightforward. I am making my practice like that. You need to give option to patient that don't go forward for IVF. You are younger, you can get pregnancy. So rather than to do IVF, you go for immunotherapy, wait for 3, 4, 5, 6 months because your other reports are fine. Might be possible that you will, and that will be a more good idea rather than to expand and involve the whole body and doing PGT and everything, right? So if they get pregnancy, that will be great. So this is my suggestion to population also, okay, that giving immunotherapy in younger age when you are having very much recurrent pregnancy loss, yes, it is advisable that might you get a natural pregnancy with the immunotherapy. This is not one experience. I will not share all experience in a very short time, but this is one patient. There is a one good carry home message. Now, second carry home message I can say about the recurrent pregnancy loss, and that lady is, I just forget about the name, but I think so she is having 8 abortion and she lose the hope. So they say something, we will not do uh, IVF, nothing, this is abortion, IVF भी क्या कर पाएगा, कुछ नहीं कर पाएगा. So sometimes क्या होता है कि people are whispering something in their, means their era around them, whatever the people are saying that, okay, so they are very much learning, right? Now somebody from the pharma division, they explained that you go to Dr. Jayesh, they started something about the recurrent pregnancy loss division, right? And they will just take a consultation. When she arrived here, I said something, you will get your own egg, 39 running. I said, you will get your own egg. This is our multiple course. You required immunotherapy, but you required PGT, you required ERA, you required hysteroscopy, you required freeze-all, everything. She went through one pickup only and she is polycystic ovary. We get at 39 also, we got a lot of embryos, a lot of eggs. And out of that, we found something 4, which is PGT normal. Everything others are abnormal. Then we perform the hysteroscopy. Because of the multiple abortion, there are some septa which was removed. We had performed ERA, which is also changed to 142 hours. And then we send the patient to you. You had performed the immunotherapy, then we wait for 1 or 2 months. And then we transfer a single embryo by PGT. And at present, she is going on around 30 weeks pregnancy is there. Right?
Oh,
so this is 8 abortion. Let me tell you to all that 8 abortion. This is the highest number of the abortion I am saying that which was treated by me, 8 abortions. Now I am coming to the point something about it's 8 abortions and people are saying that should we wait for 8 abortions? I said no. There is no need to wait for 8 abortions. So that's why I'm coming to now other patients, those who are very much aware and they are coming earlier. And that is the one patient which is coming up around. So see, it is all about you, but I can say, okay, 2-3 abortions, it's fine in the community. Might be possible that you are not going to accept it, means in a psychological way that I can wait. And might be possibly you are also not reaching to IVF expert, fertility expert, and still there is no message that there is no clinic in the world which is considered as a recurrent pregnancy loss clinic, right? Where I think so I hear something in a lot of countries, those who are running only recurrent pregnancy loss clinic, right? That will be great if recurrent pregnancy loss clinic, the patient, those who are recurrent pregnancy loss, they can go there, they can get some advice earlier. But these are some group of the patients may have a 3 to 4, and now I make a funda that if there is a 3 or more than 3 abortions or something 4, my guideline is immunotherapy. If it is less than 12 weeks, then again 100% immunotherapy. So I'm explaining them 100% immunotherapy if there are 3 or 4 more than abortions. Yes, if there are only 2 abortions and they are having a long-standing infertility, after that 2 abortions, then I will say, okay, if I have a more number of the embryo, I will reserve the immunotherapy if PGT era is not going to solve your
right.
So this is again one carry home message that initially PGT era will also help it out to make your good embryo, good quality embryo, and where we can also go through the minor, very minor genetic examinations and also history and everything to find out any genetic mutations in the karyotyping or CGHRA karyotyping, all these things. So if any CNV changes will be there, we can find out or something, and we can give them a good pregnancy. Now we understood also some certain non-specific genetic changes like 9QH plus and everything in a female, other also. These are also people are creating more aneuploidy. So
Right.
people can have a PGT and then advantage. But if even multifactorial, then we have to do LIT. So I'm saying that about the recurrent pregnancy loss, it is not a first, I think. So Dr. Raut will accept the lot cases we are sending you. All are very much interesting for Dr. Raut also, because he's so enjoying. He always calling me, Dr. Jayesh, you had done everything methodically. If this patient will catch the pregnancy, that means immunotherapy is working. Right? Am I right or wrong?
Right.
Because
I
you
think
are doing something empirically, then it's not going to work. You also are not satisfied. But when you say something, everything is done, and it's, if she's not conceiving, if she's aborting, it means that the immunotherapy is having a role. And that is what I'm always sending the patient to true indications. And you always love to say me, always smiling, your face are always smiling on phone also. And you are saying, Dr. Jayesh, I love to say something like that, okay, this is a methodical approach that we are doing. And we are love to say something at the end of the day that you are the doctor, where if pregnancy is there, you people are so much happy at the end of the day, because then you can understand a true role of LIT therapy in that.
Absolutely right, Dr. Jayesh. I think that's why we enjoy working with you. And that is the secret of your success, what you have said, this methodical approach. And I think what I remember of all the patients you have sent, I think 80-90%, at one stage you had said 100% patients have been successful. So I think a huge number have been successful. And we really enjoy this process, as you said. Why? Because we know for sure that in this patient, LIT has worked, because rest everything has been ruled out. So that's a great approach.
Only one patient is there from your side, only that one patient where LIT is not working. Might, but I'm not saying not working. She is frustrated. I advise her to go for another transfer, but she is frustrated and she converted her pregnancy to surrogacy. Apart from all patients, the number of the patients, we are always conceiving the next cycle. And they are getting a carry from pregnancy of 9 months with a good weight also. That is also amazing. They are not delivered at preterm or something like that. They delivered at a good weight around more than 2.5 kg. So this is also good news that LIT is always making the body in such a way that they are getting pregnancy and live birth rates are increasing, and it's also a good baby weight also.
So you have noticed even the pregnancies are uneventful. Means there is no side effect as such of LIT.
No patient is complaining me any side effect. That will be always plus point of this therapy, and that's why it is acceptable. I'm always pushing my patient that nothing is a one day, and Dr. Raut is working on Sunday also. This is so good that my patient is saying, amazing, Dr. Raut patient, that he is working on Sunday also. And I'm sending anytime I'm saying Dr. Raut, he say, okay, you can send on Sunday also. So I'm so glad to say something. This type of doctors are really blessed for the society.
Thank you very so much. Now, before we end, there is one more thing about your wings. So we have come to know that you have always been thinking about patients in a how you can help patients in a better way, and you have started different specialties. I think recently you have even started with an endoscopy, with an expert endoscopist at your place, and you have even conducted workshops. So I think wings is becoming a sort of a complete one place to go for all gynec problems. I think it looks like. Can you just share about your vision?
Dr. Raut, in this during the COVID times, my lot of plans which was really failed because we are not able to execute it. And we are doing egg freezing so many years, but that's fine. I'm always not giving any shout in the market until and even I don't completed certain numbers, right? And then we are having a very good output now, egg freezing. So we started egg freezing, and you can say something that it's our what we can say something. The RJ Devki is there. She shared. She is 40 years, and unmarried, and she want to plan her pregnancy later on, and she came at our clinic. RJ Devki is one of the very, very much famous RJ here in Ahmedabad, and she frees her eggs at our center, right? Later on, I can say something about that. We started also genetic disease division. So I'm much more genetic screening is important, but there are a lot of genetic disease. So we started the affiliation of one Markela Mackinson's from UK. Our clinic is where some genetic disease where say something no mutation was found and still there is abortion. So the data is less. That clinic is having a less data. Maybe they are running only 2000 mutations, but might somebody is having a more data, maybe 5000 mutations. So you can find out that mutation, pick it up that mutations, and you can help these patients, right? So you are working on this genetic diagnosis also, PGD, that is called some very known disease. And sometimes you say who suffer from this type. There are a lot of patients if you say so, right? And lastly, because of this launching division in 2020-21 is we are much more interested that I already say my first passion is laparoscopy that I started, not IVF, right? So I love to do laparoscopy, but I am not doing laparoscopy. So sometimes what happens, the patients are coming and they will go to other places. And I am also sometimes say, okay, this surgery is not, because suppose you can understand, suppose you're somebody relative of Dr. Raut, and she's coming at my center for fertility, but then I say it's a very difficult surgery which is required, so I have to send that patient to a very proper person. This is my always practice. I don't believe in something to doing everything by you where you are not expert. Send the patients where expert is available. Now this is the era of expertness, focusedness. So it's not like earning, I will call that expert at my clinic and earning everything at my clinic. These days are gone. But I am waiting for a good laparoscopic surgeons. I know that until 2021, I am not having that much of good laparoscopic surgeons, those who are doing something all peritoneal node sampling and very aggressive lateral pelvic dissections and everything, which will be, I'm not saying that it's not available in India. There are a lot of surgeons, good surgeons, senior surgeons are there. So I want to make it out that let us have a one more young, good people will come out and they will be standing for the future generation. My seniors had done good work, but then done for next what, right? So this is Dr. Divyesh Panchal joined with us, and he is a very expert. He is also having a 2 years fellowship in Tata Memorial for Cancer Research, and he's doing fantastic. I think so. I had shared the video also, and
yes.
fantastic surgery. We have much more more workshop on deep infiltrating endometrium. So we name that department is redo surgery department. It's we don't want something to go for normal hysterectomy and like that. It's a redo surgery. Means once the laparoscopic surgeon is failed, you come at my place. We will do it. So we are interested in redo surgery. I am basically known for recurrent IVF failure. If I say Dr. Divyesh Panchal that okay, we will focus on redo surgery, we are not interested in simple surgery. Let people do the surgery. If they fail, then we can do the surgery.
So I think all these things are going to make your center really unique and a center of excellence, we can say.
Would you like to give some take-home message to the audience, because our audience is going to be doctors, patients also. So
Yes.
what would be your take-home message for the audience?
See, my take-home message is one most important thing is that now don't waste your time first. So Indian genetics is very poor. So as early as possible, you can go through whenever you are having a problem, you can have a preconception counseling. That funda is still not aware in our population. So if you are having a multiple abortion, you can have go and meet the something expert and have what are the treatments are available, what will be the age which is important. That is the first message, right? So at right time, if the right treatment will offer to the patients, to our genetics, Indian genetics, then it will be great. Second thing is that for those who are having a pregnancy loss, so sometimes it's still not aware that if you have a 3 embryo, 4 embryo, or 3 abortion, 4 abortion, then there are a lot of people are advising to change the eggs. Don't change the eggs. It is all time to get the advanced treatment with PGT era and associated with LIT therapy, right? It is whatever the study are saying 75, forget about the numbers. Take the part of the treatment. If you are just focusing on numbers, which is always going to be number. So always I say something about to come out and go for the LIT therapy. Now it is available specifically for those who are having a multiple abortion. But I can say something, there are two approach. One approach that you can just very younger and you can go ahead for LIT therapy and wait for nation pregnancy. There is a one approach that is fine. That is a good approach. Let me tell you, I'm cutting my legs, but I'm saying that this is a good approach, right? Because I am interested in my community, where community is benefiting. And second thing is that if you are still abortion, then you require some genetic testing, right? ERA is always dynamic. It's not required to all, but genetic testing and then LIT combinations will give you a better pregnancy. Recurrent implantation failure that we are discussing with Dr. Raut, I do not have a lot of patients, those who are having required LIT, but future, in a next stop, if I accumulated recurrent implantation failure and LIT is really going to helpful, then I'm really interested, because then what will be the end of that patients where after PGT era, still they are not getting pregnancy. Let us discuss in the second talk whenever we are meeting. But at present, I can say something. LIT is the last crux of this whole discussion, that LIT plays a major role in recurrent pregnancy loss. There is undoubtedly, and my experience, a lot of I say it is a very structurally assessed. So if somebody is hearing from IVF especially, I say it's that all patients are assessed by genetic testing, all patients are assessed by ERA, freeze-all, one transfer, they have abortion, and then I send it to Dr. Raut. And then this patient is continued for 9 months. So it will say that LIT is one of the most important portion which is required for the recurrent pregnancy loss.
Okay, thank you. I think this was an excellent interaction, Dr. Jayesh. We got to know many new things about you, about your work, and about your experience. And the take-home message was also to the point and very specific. I think.
Thank you so much for inviting me, Dr. Raut, and you both are working very good, because getting a pregnancy, not getting a pregnancy is a pain, but getting a pregnancy and abortion is a double pain. So you are healing double pain, right? I'm always saying it's a crying, it's a frustrating, and it's a lot of other involvement of the females, and where really we are interested, they are saying that this is a great treatment which is available across the India by you, and we are so happy to saying patients now that you will be free of these abortions with the treatment of Dr. Raut clinics. Thank you so much.
Thanks, sir.
Thank you so much.
Right, we are happy that we are complementing the great work that you have done, and of some help and use to these unfortunate patients. Thanks a lot.
Thank you very much for taking your time for coming to the show.
Okay, thank you so much.